Welcome back to Not So Complicated, and today we will be talking about pharmacology straight from USMLE Step 1 First State 2025 session, and then out of that we will be covering pharmacokinetics in this session and pharmacodynamics in our another session, right? So we'll be starting from a quote. Love is the drug I'm thinking of. It is such a good quote, right? I love this. And then we all know pharmacokinetics is what body does to the drugs, right? So there are four initials that we have always heard about, that is ADME, that is absorption of drug, distribution of drug, metabolism of drug, and then elimination of drugs. We'll be talking about each of these in details in today's session, and we'll be starting from enzyme kinetics. There are two ways to understand the enzyme kinetics, and they are Michaelis-Menten kinetics and then Lineweaver-Burke plot. Both of these are very important, and we have to understand this very well. So let's begin from Michaelis-Menten kinetics. Km, we have always heard about Km, right? So what actually is Km? Km is the substrate concentration. It is a constant. It is a substrate concentration needed for an enzyme to reach a rate of half of Bmax. What is Bmax? Bmax is actually maximum reaction velocity. What reaction? Any enzyme is reacting with a substrate to give the product, right? And substrate here is a drug. So any enzyme reacting with a drug gives a product, and that happens in a reaction, right? And that reaction has a velocity. The maximal velocity of that reaction is Vmax, and reaching half of this maximum velocity, right? Substrate concentration needed for an enzyme to reach a rate of half of this maximal velocity is Km. So that is what Km is. So we will be talking about this graph in later session. So later part, Bmax is directly proportional to the enzyme concentration, right? So the more is the enzyme, there is the velocity maximum, right? So maximum velocity, so Bmax is maximum, and it is inversely related to the affinity of the enzyme for its substrate. You have to remember this. Affinity is the ability of anything to bind with anything. So that is affinity, right? So the affinity of enzyme for its substrate, so that is inversely related to the Km. So most enzymatic reactions follow a hyperbolic curve. So hyperbolic curve is a normal curve for Michaelis-Menten kinetics. We have to remember this. However, enzymatic reactions that exhibit sigmoidal curve, it can also happen. Sigmoidal curve can happen in Michaelis-Menten constant or equation or kinetics, right? So they indicate positive cooperativity in substrate binding. Example, aspartate transcarbamylase, that is an enzyme that shows a sigmoidal curve, right? You have to remember this, very high yield. It can be asked in USMLE Step 1. So let's just talk about these curves here. This is very important for us to understand. So S is a symbol for concentration of substrate, and B is for the reaction velocity, right? So you can see here, Bmax is the maximum reaction velocity, so that is the saturation point of level, and half of Bmax is the point where the substrate concentration is needed, right, to reach that state. So this is the Km. This is the definition of the Km. That is Michaelis constant. It is substrate concentration, the amount of substrate concentration needed for an enzyme to reach the half of this maximal velocity. So this point right here is about Km. That is Km. You have to understand this. And effects of enzyme inhibition. This is a normal situation, right? So let's talk about what happens in the enzymatic situation, like inhibition. There are inhibition of those enzymes. There can be competitive inhibition, non-competitive inhibition, or uncompetitive inhibition. There is no uncompetitive inhibition in this graph here. So let's talk about competitive inhibitors and non-competitive inhibitors. So in competitive inhibitors, what is happening is that enzyme is getting inhibited, right? So even if the enzyme is inhibited, then the reaction velocity should have been slowed down, right? So it reaches saturation point in a less curvy manner, less faster. So Bmax is reached less time, in a very less time. than in normal situation, and that happens more rigorously if the inhibitor is non-competitive. You can see here it happens more rigorously, right? So it doesn't even reach Bmax at this level. So in competitive inhibitor, Bmax is reached, right? So Bmax is same for normal situation and in the presence of competitive inhibition. Bmax is reached, but it is reached later, right? So more substrate is required to reach the Bmax, right? So the Km is increased in this case, but Bmax is normal in competitive inhibition. But in non-competitive inhibition, Bmax is not reached and even Km is not reached. The level of Km is not reached, right? So both of them are decreased in non-competitive inhibition cases. So that is what you had to get from this graph right here. I will just quickly revise it. So what is happening? Saturation is happening in normal situation and also in competitive inhibitor, that is reversible competitive inhibitor situation. In both of these cases, Bmax is reached, but there is a gap in between, right? There is a slight gap in this between. So in the presence of competitive inhibitor, so Bmax is reached a little later, right? But so that means the Km is increased in this case because substrate concentration is increased to reach the same Bmax or half of the Bmax, right? So in non-competitive inhibitor, both of them are decreased because it even the reaction velocity, maximum reaction velocity is not reached in this case. So let's talk about Lineweaver-Burke plot. So the closer to 0 on y-axis, the higher the Bmax. So this is 0 in y-axis. So closer a person, let me just decrease the thickness of this line. 2 points is enough maybe, yeah. So the closer to 0 on the y-axis, this is y-axis right here. So the higher is the Bmax, right? If this is the point where a reaction velocity is maximum, right? The closer to 0, the higher is the Bmax. You can see the farther you go, the lower is the Bmax. It is inversely proportional. You can see 1 by V in y-axis. The closer to 0 on x-axis, the higher is the Km. You can see here, right? In the x-axis, the higher is the Km. So it happens negativity here. In uninhibited thing, there is a slope of Km by Bmax plotted in this graph, and it goes to the negative x-axis. And the more it is closer to the 0, what happens is the higher is Km. It is also inversely proportional, but in negative x-axis. It is inversely Bmax is inversely proportional in positive y-axis, and then Km is negative, like inversely proportional in negative x-axis, right? So the higher the Km, the lower the infinity. It is the rule. It is same rule like in Michaelis-Menten equation. And reversible competitive inhibitors cross each other, whereas non-competitive inhibitors do not cross each other. You have to remember this in this curve right here. So reversible competitive inhibitors have crossed the uninhibited slope of line, like while plotting in this curve 1 by V to 1 by S curve. Competitive inhibitor crosses on inhibited slope, right? But non-competitive inhibitor doesn't cross it. So you have to remember this. So competitive inhibitors increase Km. You can remember like this. Km. So Km. I have a better way of remembering this. So Km looks like kilometers, right? So in competition, you have to run more kilometers. So in competitive inhibitor cases, Km increases. So that is how you can remember the other way. So let's talk about these differences. Competitive inhibitors, reversible, irreversible, and non-competitive inhibitors, which are almost always irreversible, except one case. We will be talking about that too. So, do competitive inhibitors resemble the substrate? Yes, they do. And competitive inhibitors irreversible? They also do. But they do not resemble any substrate. So, they are overcome by increased substrate. Are they overcome? Like increased substrate concentration? Yes, they are overcome. but they are not, and they are not either. So binding active site, they bind active site. Enzyme has two sites, right? So this is active site, this is the site other than active site, which is called allosteric site. So if it binds active site or not. So competitive inhibitors reversible, they bind active site, they also bind active site, they do not bind active site, which means they bind allosteric site, right? Effect on Bmax, it is unchanged. In competitive inhibitors reversible, because increase in substrate concentration will make the reaction reach Bmax at any cost, even if the time is delayed. In competitive inhibitors irreversible, it is not reached, and then it is not reached in non-competitive inhibitors either. So effect on Km, it is increased, unchanged. In pharmacodynamics, it is decreased potency. What is potency actually? It is a measure of the amount of a drug needed to produce the response. That is potency, right? So it is like competitive inhibitors reversible, there is decreased potency and there is decreased efficacy in other two cases. Efficacy, it is the maximum effect produced by a drug. So that is decreased in competitive inhibitors irreversible and non-competitive inhibitors. So competitive inhibitors are usually reversible, but they are irreversible in cases like organophosphates, right? In drugs like organophosphates. And in non-competitive inhibitors, they are irreversible in usual cases, but they are reversible in cases like carbonic anhydrase inhibitors. That can happen. You have to remember this, right? Note it down right now. This is very high yield for you. And then let's talk about bioavailability. What is bioavailability? It is indicated by F, right? It is a fraction of administered drug reaching systemic circulation. Like say it, you have administered any drug orally or intramuscular, intradermal, subcutaneous, intravenous, any route of administration, even rectal or intrathecal, any route of administration. It is the fraction of that administered drug in systemic circulation, which means inside the blood vessel, that is in blood vascular compartment, right? So that is the bioavailability. So for an IV dose, F is 100%, because in intravenous doses, you inject drug directly to the veins. The vein is a blood vascular compartment, so there is 100% is bioavailability. But in oral cases, bioavailability decreases typically due to incomplete absorption from the GIT and first pass metabolism. For a drug to reach the systemic circulation, it will first get absorbed by the portal vein, reaching the liver. And in liver, there is metabolism occurring, phase 1 metabolism, phase 2 metabolism, all of that is happening in liver, right? So some of the drugs are metabolized in that region and is not available in systemic circulation. So the bioavailability is decreasing in the oral cases and other cases, right? So it can be calculated from the area under the curve, AUC, area under the curve, in a plot of plasma concentration over time. So this y-axis here is plasma concentration, and then this x-axis here is time, right? So this is the graph. So AUC IV, that is area under curve in intravenous doses, is this much, this high, right? This is 100%. Area under curve in oral cases, this is very small. And then AUC, it is calculated via a formula called AUC oral times dose in IV by dose in oral times AUC IV. This is the bioavailability calculation. So let's talk about volume of distribution. What do you understand by volume of distribution? The absorbed drug now moves through the body, right? So where is it going? Where is it staying? That is what a volume of distribution is. So that is a theoretical value that relates drug amount to plasma concentration, right? So liver and kidney disease increase BD, that is decreased in protein binding, increased in BD. So let's talk about it. So how does any drug gets distributed? It is stored in tissues. You have to remember this point, tissue. All drugs store in tissue, not all, but they get stored in tissue, and the extent of storage in these tissues is volume of distribution, right? So if they are not stored in these tissues, so that means that either the drugs have been binding to proteins, or it has a very less volume of distribution, right? So in any blood vessel, a drug reaches, and then there are a lot of proteins there, and these proteins bind these drugs, right? And binding of these drugs will lead to not being able to get stored in the tissue. So the more the protein binding is, the less the volume of distribution will be. So in liver or kidney diseases, what actually happens is there is decrease in protein synthesis, so decrease in protein binding, leading to increase in volume of distribution, right? So that means increased storage in the tissues. So if the drug is stored in tissues, what actually happens? We need drugs in systemic circulation, right? So the maximum or the more the drug is stored in the tissues, the more the dose of the drug is to be administered in our body. So if a drug has a maximum volume of distribution, we should be administering more dose of that drug to reach the normal efficacious potency level, right? So that is called loading dose. That is why we need loading dose to reach a stable state. To reach a stable state. So the drug having highest volume of distribution is chloroquine. It has 1300 liters per kg of distribution, right? So drugs may be distributed in more than one compartment. Hemodialysis is most effective in drugs with low BD because hemodialysis works in a concept of filtration, but proteins cannot get filtrated, right? So the more the protein binding is, the less the volume of distribution is. So hemodialysis is most effective for drugs with a low BD, obviously, because the drugs are stored in the tissues also. So the drugs stored in tissues cannot get filtered out of the kidney, right? So that is why hemodialysis is here. Now let's talk about the formula. Volume of distribution is amount of drug in the body by plasma drug concentration. So volume of distribution can either be low, medium, and high. So in compartment, so if the volume of distribution is low, the drugs are in intravascular compartment. In medium, it is in extracellular fluid, and in high cases, it is in all tissues, including fat tissues. So drug types: large charged molecules or plasma protein bound molecules have low BD, and then small hydrophilic molecules have medium BD, and small lipophilic molecules, especially if bound to tissue protein, have high BD, right? So let's talk about clearance. What is actually a clearance is? Clearance is the volume of plasma cleared of drug per unit time. That is clearance, right? It is a volume of plasma cleared of drug per unit time. So this is a very confusing thing. All of these people's all of the students get confused in this definition. So just remember, this is a portion of your blood where there is no drug per unit time, right? Like you have a drug, you have drug in a portion of your blood. Now you don't have that drug in the same person. That is clearance. Simply that is clearance. So the volume of plasma cleared of drug per unit time is clearance. So clearance may be impaired with defects in cardiac, hepatic, or renal function. Clearance is actually calculated via rate of elimination of drug by plasma drug concentration, that is BD times Ke, that is elimination constant, right? So half-life, let's talk about half-life. Half-life is the time required to eliminate half of the drug from the body. It is very easy to understand, right? Steady state is, you have to remember this concept right here. Steady state is a dynamic equilibrium where the rate of administration is equal to the rate of elimination. You have to understand this. Steady state, rate of administration is equals to rate of elimination. So in first order kinetics, a drug infused at a constant rate takes 4 to 5 half-lives to reach steady state. In first order kinetics, it takes 3.3 half-lives to reach 90% of the steady state level. So how do we calculate half-life? It is 0.7. It is actually 0.693. 0.7 is written for the calculation to be easier. So in first order elimination, it is 0.7 times BD by CL. So we also have a thing here. if a rate of elimination depends on plasma concentration or not. We can do that. So R is rate of elimination directly proportional to plasma concentration to the power order of reaction. You have to remember this. So if the order of reaction is 0, so Pc to the power 0 is 1, right? So rate of elimination is constant in 0 order kinetics, and it is directly proportional to plasma concentration in first order kinetics. So you have to remember this, right? In half-lives, in one half-life, the percentage of remaining drug is 50%, in two half-lives 25, three half-lives 12.5, 6.25%, and this goes and goes and goes on, right? Let's just calculate doses here. Loading dose we calculate by target plasma concentration into volume of distribution by bioavailability, and in maintenance dose it is target plasma concentration clearance times doses interval by bioavailability. So this tau here, a dose interval, time between doses, it does not apply in continuous infusions, so it is just eliminated, omitted in calculation if it is a case of continuous infusion. So in renal or liver diseases, maintenance dose is decreased and loading dose is usually unchanged. Time to steady state depends primarily on half-life and is independent of dose and dosing frequency, right? So let's talk about drug metabolism. There are two ways a drug metabolizes. It is phase 1 reaction and phase 2 reaction. So drugs can be metabolized by either or both phase 1 or phase 2 reactions. These reactions serve to bioactivate or deactivate substances. Metabolism does not always mean activation of drug. It can lead to deactivation of drugs too. This is a common misconception that people have, right? So you have to understand this. And they do not have to take place sequentially. So phase 1 can follow phase 2 or take place as a single reaction. So it does not have to occur sequentially. In geriatric patients, they lose phase 1 first, and then patients who are slow acetylators have increased adverse reactions or effects from certain drugs because of decreased rate of metabolism, like in isoniazid. So we'll be talking about isoniazid in our tubercular drugs portion, right? So there are metabolism slow acetylators and fast acetylators. These are patient-specific variations. There are two types of drugs. We all know lipophilic drugs and water-soluble drugs or polar drugs, right? So these lipophilic drugs, they go phase 1 reactions at first. So predominantly CYP 450 dependent. What is CYP? It is cytochrome, right? And 450 is, and CY is cytochrome and P is pigment, and 450 is the wavelength of light, 450 nanometer, where the pigment has maximum absorption of that light. That is CYP 450. It has different families, right? CYP 3A4, 2D6, 2C19. These are the families, subfamilies, and selective isoforms of these drugs, and they do either reduction or oxidation or hydrolysis, and they will finally lead these lipophilic drugs to slightly polar metabolite, active or inactive, and also reactive oxygen metabolites. And in polar drugs, that is water soluble drugs, they will go to phase 2 reactive oxygen metabolites. They can go directly to the, like phase 1 reaction can convert into the phase 2 reactions, and phase 2 reactions can convert into the phase 1 reactions. This is also the common misconception that they happen simultaneously, sequentially. That is not the concept. So in phase 2 reactions, these reactive oxygen metabolites formed in phase 1 reactions, usually they do undergo methylation, glucuronidation, acetylation, and sulfation, and that will lead to very polar hydrophilic metabolite, except acetylated metabolite. The formation of that happens, and they will get excreted by serum, either urine or sweat, or bile by a stool. So that is how the elimination occurs. And these enzymes right here can be microsomal enzymes, non-microsomal enzymes, right? And they have specific inducers and inhibitors. That is very important in drug interactions. It is not in here right now, so I won't be talking about it. We'll be talking about in a different session for that. Drug inducers and inhibitors, that is very important. So let's talk about elimination of drugs. So zero order elimination. I have talked about this formula here. Rate of elimination is directly proportional to plasma concentration to the power of order. So in zero order elimination, rate of elimination is constant. We had talked about why, regardless of CP, that is constant amount of drug eliminated per unit time. In this case, it is constant amount of drug, but in first order kinetics, it is constant fraction of drug eliminated. You have to remember this. It is constant amount in this case, and it is constant fraction in this case. So plasma concentration is decreasing linearly with time. Examples of drugs are phenytoin, ethanol, and aspirin at high or toxic concentrations. Aspirin follows zero order kinetics only in high or toxic concentrations, right? So you can remember zero order kinetics. The drugs that follow zero order kinetics is 0 watt power, WATT, 0 watt power. So basically, T, W is warfarin and heparin, alcohol and aspirin, and then T is tolbutamide, T is theophylline, and P, 0 watt power, P is phenytoin, and also ethanol, it belongs to alcohol obviously, and aspirin. Aspirin at very high doses and toxic concentrations only, not in low doses. So it is capacity limited elimination. A P is round, set like the 0 in order. This is another mnemonics presented here, but I prefer to remember this like 0 watt power. And in first order elimination, rate of first order elimination is directly proportional to the drug concentration, that is constant fraction of drug eliminated per unit time. So CP decreases exponentially. So in zero order kinetics, it decreases linearly, but in first order kinetics, it decreases exponentially with time. Applies to most drugs, right? It is flow dependent elimination. This flow dependent elimination. Here you can see the graph. In zero order kinetics, constant amount of drug is decreased, 2 units per hour, 2 units per hour, 2 units per hour, right? First half-life, second half-life, and third half-life, constant amount. And in first order kinetics, it is, the curve is like this, right? It is linear in here. It is exponential in here. So that is how it decreases in this curve. Let's talk about urine pH and drug elimination. How does urine pH affects the drug elimination, and what kind of drugs, like weak acidic drugs or weak basic drugs, what should be the environment of the urine to get the maximal excretion of those drugs, right? So ionized species are trapped in urine and cleared quickly. So here is the concept. Any drug that is lipid soluble can either be ionized or unionized. In ionized cases, it is water soluble and excretion is faster. And in unionized cases, it is lipid soluble and the absorption is faster, right? So absorption of drug is faster in unionized form and excretion is faster in ionized form. So neutral forms can be reabsorbed. And in weak acidic cases, like phenobarbital, methotrexate, aspirin, salicylates, or barbiturates, right? We have to treat overdose with sodium bicarbonate to alkalinize urine. So these weak acids get ionized in alkaline medium. So it's about pH and pKa actually, right? So pKa of a drug and pH of the medium are very closely interrelated. So basically, if a weak acid is present in an alkaline medium, it gets ionized. So the excretion is faster. So basically, if there is poisoning of weak acidic drugs like phenobarbital, methotrexate, aspirin, you have to treat with sodium bicarbonate to alkalinize the urine. And in weak base cases like TCA, amphetamines, and anything that has INES, amphetamines like morphine or atropine, right? So TCAs, amphetamines, they are trapped in acidic environment. So for severe alkalosis, treat with ammonium chloride, that is acidic in nature. So we are providing acidic medium to the alkaline drugs to acidify the urine, right? So that is again gets either reabsorbed or excreted. So TCA toxicity is initially treated with sodium bicarbonate to overcome the sodium channel blocking activity of TCAs. This treats cardiac toxicity but does not accelerate drug elimination. So it does not get like if the environment of urine is acidic, it gets reabsorbed in weak basic cases. But if we acidify this urine, it will always be excreted. in weak basis cases. So what is pKa? It is a pH at which drugs like weak acid or base are 50% ionized and 50% non-ionized. You have to remember this pKa. pKa represents the strength of the weak acid or base. Here is the graph. So this is the common point. This is the cross-section point, 50-50 point, where 50% is ionized, 50% is unionized in drugs, right? So, so decreased pKa means more acidic, and increased pKa means more basic, obviously. So this is last for today, efficacy and potency. We'll be talking about, I have talked about the definition of efficacy actually. So maximal effect a drug can produce, that is intrinsic activity, is efficacy. Amount of drug needed for a given effect is potency, right? So efficacy, it is represented by Y value, Emax in here. Increased Y value, that is increased Emax, that is increased efficacy. Efficacy is increasing in this case. So unrelated to potency, it is very unrelated to potency. That is, efficacious drugs can have high or low potency. That is, equally efficacious drugs can have different potency. You have to remember this. And equally potent drug can have different efficacy. This is like universal. And then partial agonists have less efficacy than full agonists. So relative efficacy, drug A is here, drug B is here. This is log drug dose, right? So maximal effect is different for two different drugs. So this is the difference of efficacy. So that is how you remember this. And in potency, amount of drug needed for a given effect is potency. It is represented by X value in here. Log drug dose. It is about the dose. It is about the effect, right? Potency is about dose. It is about the effect. E for efficacy, for effect of that drug, right? And then, so this is drug A and this is drug B. To reach the same level of efficacy, these two different drugs are requiring two different doses. So here you can see in drug A, there is lesser dose, right? Even in this less dose, it is reaching maximal efficacy. But in this higher dose, like drug B requires a little bit higher dose than drug A to reach the same efficacy level. So this is the difference of potency. So if a drug requires less dose to reach the efficacious level, the same efficacy level, that is highly potent, right? And if a drug needs more doses to reach the same efficacy level, it is less potent than the other drug. So that is what you have to remember in potency and efficacy. So that is all about today. We'll be talking about receptor binding and pharmacodynamics in our another sessions. Thank you if you are still here. Thank you for staying with me and subscribe for more clinical pulse. Thank you.